All right. Good morning, everyone. We're going to go ahead and jump right in. This morning, we are in chapter 41. We have our GI system that we're going to start with. Might finish up with the GU system. Otherwise, we'll do that on Monday and then follow that with the review. Okay. So some of the nutritional problems that can happen, this is something that can happen in all age groups. It's not something that only happens in the pediatric group, but like some of the other things that we've talked about, the reason that GI problems become a bigger problem in our pediatric population a lot faster than they do in the adult population is because they don't have those compensatory mechanisms where the body tries to figure out how to get things together before there becomes a problem. Okay. Other big factors that we have to look out here, if we're talking about health promotion and educating our population, our pediatric population, we want to think about trying to provide that information about starting healthy. Most children, like we've covered, start eating solid food somewhere between 4 to 6 months, depending on the pediatrician recommendation, depending on where that child is at developmentally. And we typically start with some type of fruit. It could be bananas mixed with breast milk or formula, something like that. Depends on what the preference of the family might be. But we want to encourage those healthy eating habits early on. Children figure out or develop their flavor profiles by about 3 years of age. So if they've been exposed to healthy fruits and vegetables, healthy meat, and that kind of thing, typically those are patterns that they're going to carry on into their adolescence and into adulthood. It's a lot harder to change those habits if families get in a pattern of doing a lot of fast food, for example, because the lifestyle that they live is just so busy, taking kids to school, baseball games, working, and all of that. So really encouraging those healthy eating habits starting from a very young age. The other factor we have to consider here is the fact that a lot of the foods that we eat have a cultural component to them. So that is something that we would want to discuss as well, trying to include those cultural components, but still provide for healthy eating opportunities. Okay. All right. So when we start talking about GI, dehydration really could go in GI or GU. The reason that we put it in this section is because a lot of times children, dehydration is not a primary situation. People don't just get dehydrated unless they're not taking in enough fluids. This is often something that is secondary to vomiting or diarrhea. And if we look at our population, because they, our infants and young children are smaller and they don't have those compensatory mechanisms, if we have a child that has nausea or vomiting or diarrhea, they're going to potentially go into dehydration a lot more quickly. Okay. So you can see that there are different ways that we can assess whether it's mild, moderate, or severe. You guys probably remember that we can also look at isotonic, hypotonic, or hypertonic water loss. With isotonic, we've got equal water and electrolyte loss. With hypotonic, the electrolyte disturbances are greater than that water loss. These symptoms we typically see with hypotonic: dizziness, fatigue, lethargy, thirst. The child has that, that compensatory mechanism to try to balance out those electrolytes by taking in more fluid. And then with hypertonic, we've got a greater water loss than we do with electrolytes. Okay. When we have infants with diarrhea, this is the most common that we're going to see because they're not necessarily not taking in enough electrolytes, but through that diarrhea, they're losing a lot of water. Okay. So what we would potentially see in these children: irritability, dry mouth, loss of consciousness, tachycardia. And because we are looking at that great disturbance, if we don't intervene very quickly, then we are looking at potential permanent neurologic dysfunction. Okay. Whenever possible, we always want to go less invasive with our treatment. So if it's possible, depending on what's going on with our child, we want to try to start with ORT, or oral rehydration therapy. Okay. This means that the child is going to take more fluids if possible, whether it's breast milk, formula, whatever he may be eating at the time. Or if we're at that severe level, we may have to start an IV. Again, thinking about less invasive, if we can rehydrate by mouth, this child could potentially go home. Is it cutting out for anybody else? I'm just seeing Mary's comment. Can you guys hear me okay?
Yes.
We can hear you.
Okay, Mary, if your camera's on, maybe try turning that off. That might help, or just reset your router and join us. Okay. So if possible, we want to do oral IV fluids if necessary. If we have to start that IV, it means that that child is going to stay with us at least overnight until we can rebalance the water or the electrolytes. Okay. Other overall things that we see with dehydration, we're going to see those dry mucous membranes. We might see lack of tears if we have an infant who's made it to the point where they actually drop tears when they cry. Early in infancy, we can see that sunken fontanelle, that soft spot that's right here, that stays open for a while. So that can be a great indicator of hydration level. So if we were to fill it on a healthy child, if it's still open, it should feel pretty much just the same level as the rest of the skull. Okay. Shouldn't feel firm, just nice, soft and flat. Okay. If we had a child who is dehydrated, it's actually going to sink in because of that loss of volume. So as you're palpating across, you'd actually be able to feel it kind of drop down. Okay. And then we may start to see those changes in behavior through irritability, and that will progress into loss of consciousness or level of consciousness changes. Okay, so if you guys look at tables 41.2 and 41.3 on 1174 and 1175 in the new text, and it's 1172 and 1174 in the old text, it'll give you some more information that will be helpful heading into your exam about what to look for in these children as they're having these electrolyte disturbances. Okay. All right. I'm not going to spend time talking about the daily intake because I know you guys have covered that in lab already. I will just give you the great information. This is not something that you're going to have to do on your exam. You handle that with your dosage and calculations, wherever you guys are at with that in lab, not something you have to do for me. Okay. All right, it is important to note the normal pediatric output. You won't outrightly be asked to calculate it, but you may get a question that says, this is the value, or this is the 24-hour urine output for a child, and you need to be able to look at that and see if it's normal. Okay, so it's not an outright calculation where it's going to ask you the number, but you may be provided information that says this is, the 12-hour, 24-hour output, whatever the way it may verbalize it, and you'll need to know how to look at that information and determine if it's normal. Okay, so that is something that may be expected of you. All right, so now let's talk about diarrhea. So remember, this is not it's not just a condition, right? It's something that happens secondary. We know that this can be related to infection, can be related to some dietary issues like celiac disease. If it is an acute situation, just came on all of a sudden, typically we're looking at an infection or possibly, food just didn't process well with that child. Okay. The best thing that we're going to do here is get great information from our parent or caregiver to really look at that history. What is the child's normal bowel movement pattern? Does he poop every day? Is it once a day, twice a day, 3 times a day, etc.? The smaller the child is, typically the more frequently they stool because the digestive system is smaller. Things work through a lot more quickly, starting with that newborn period where we typically see them have a bowel movement after every feed. And then that should space out as that child gets a little bit older. But we really need as much history as we possibly can, what that child is eating, when he last ate, when was his last normal bowel movement, because that's going to help us kind of point our heads in the right direction of what our cause is. Okay. Lab testing is not usually helpful as far as looking at the stool unless we suspect blood in it, or if we're looking at a more chronic issue. Okay. The other big factors or big information that we need from our parent, if we don't have a stool sample, is we need them to give us as much information. Think about some of your past CPEs where you've had to coach that stool specimen, where you ask about the color. We typically see stool kind of being different shades of brown. So that color can be really indicative of what's going on. So for example, if we had watery, explosive stool, we may be dealing with glucose intolerance. Foul smelling, greasy stool, like we covered yesterday, that's steatorrhea, that's fat malabsorption. Okay. Bloody stools could indicate bacterial GI disorders. And then if we have mucousy stools, we're looking at inflammation. Okay. Could be an infection, could be IBD, Crohn's, something like that. So if we have mucus or blood, we're going to test that stool. We're going to do a guaiac test, because now we're potentially thinking if there's blood in the stool, we may have an infection, and that's something that we could potentially treat if it's bacterial. Okay. So we don't always do lab work when a child has a virus. And remember, it can be secondary as well. The child can have an upper respiratory infection, and because of, the body's kind of going crazy, some children will present with diarrhea. So it doesn't mean that there's an infection in that digestive tract, just means that is how that child is presenting. Okay. Very common in our infant period. You can see some of our causes there: gastroenteritis, enteritis, colitis, enterocolitis. All of these are different inflammatory processes, and are often related to some type of GI bug that has got in there. Okay. If you guys have had kids in daycare, you know that they take diarrhea very, very seriously. I can remember my child is in a home daycare now, so he's not as exposed to as many children now. But when I first went back to work after my maternity leave, he was in a public daycare. And the first time he had diarrhea, I remember, like, I literally had to leave the middle of my work day and go take care of him. And then I got home and it was literally nothing. He had no more. It was one runny stool, which if you look at textbook definition, is not diarrhea. But they wanted me to come pick him up, and, he stayed home with me for 2 days, literally had no more runny stools, and it was a big waste of everyone's time. But the reason that daycares take it so seriously is because if it is an infection, it can spread pretty rapidly. And my son was about 6 months at the time. He was able to handle, it wasn't an infection, but he would have done a decent job handling that infection. He was still in the infant room. So if there was, a younger baby there, it could have gotten him a lot more sick. So I definitely see why they take it very serious, because it can be so bad. But in that case, it was nothing, just one little runny stool. All right. So when we're looking at dehydration, as we've already covered, we always want to do the least invasive. If the child is actively vomiting, oral rehydration therapy is not going to work, because everything we're putting in, they're just going to purge right back up. Okay. So if we've got vomiting and diarrhea, and we're at a point of dehydration, we're most likely going to start those IV fluids. Okay. If we can do oral rehydration, that's always going to be preferred. It's not like I'm trying to make the point. Vomiting is not necessarily a contraindication, but if everything we're putting in is coming right back out, we may have to think about those IV fluids. Okay. And then as the child moves past the vomiting and the diarrhea, we can advance back to whatever diet he was on before. Okay. We want to start with things that are easily digestible. We used to promote the brat diet, the bananas, rice, and toast, but we don't really push that brat diet anymore because it doesn't really have a lot of nutrition value to it. So really just easily digestible, non-fat, non-greasy foods. Oatmeal can be very helpful. It's kind of a solid food, a lot of fiber, can help kind of restore health to the gut. When we're looking at infection, the most important thing is about prevention. Okay. So if we have a child in daycare, that's why they want them to go home, so that we can keep the other children safe. Once that child gets back home, we want to make sure that we're washing our hands very good after diaper changes, that we're being very mindful about other children that may be in the house. Any surfaces that child may have touched, we want to make sure that we're cleaning those with Lysol or whatever products we use, because we don't want this to go to anyone else in the home. Okay, there are some bugs that can work their way through the entire family, adults included, because they are so aggressive. So prevention is key when it comes to this. Okay. All right, so here's a case study for this section. Brandon is a 4-year-old that just started preschool 2 months ago. He's brought to the pediatrician with complaints of generalized abdominal pain. The assessment yields the following data: heart rate 90, respiratory rate of 22, blood pressure of 96/52, and temp of 98.5. Abdomen is slightly distended with hypoactive bowel syndrome, bowel sounds. Mom reports that Brandon is a picky eater, but he's had 3 to 4 cups of milk each day. So before we dive too deep into this, what's going on with hypoactive bowel syndrome? Bowel sounds. What type of bowel movements would we expect to have here with hypoactive bowel sounds?
Diarrhea.
So hypoactive, we're actually going to have constipation, could be looking at an obstruction. Things are not moving through very quickly. If we had hyperactive, now we're looking at diarrhea, because what we're hearing is everything moving through very quickly, as happens with diarrhea. Okay. So we'll come back to, yes, it could be an ileus. That's another way of saying obstruction. Very good. So we'll come back to Brandon in just a second. Oh, no, right here. The physician orders polyethylene glycol for Brandon. What do you think was going on with Brandon based on his symptoms? Temperature is normal, so not expecting an infection. Anybody have any?
Just constipation.
I was gonna say just the
He
patient
doesn't have enough fluid intake.
from the milk.
Dehydrated.
Yeah, some kind of irritation. The abdomen is distended, so there's inflammation in there.
Milk will make you more constipated too.
Yeah, I think that is a lot of milk for his age group. So we may not be dealing with the lactose intolerance, perhaps just too much lactose. And like Brian is saying, there's most likely some inflammation going on there. All right, so the physician orders polyethylene glycol for Brandon. We didn't get a lot of information about his last bowel movement, but because we're hearing those hypoactive bowel sounds, we would be concerned with potential ileus or that blockage. When finishing up the visit, Brandon's mom tells you that she does not like the idea of Brandon taking medications at this early age. How would you respond to Brandon's mom?
That she could
Explain
offer
that.
him apple juice, increase his fluid intake,
I don't know if you
give him more vegetables.
or not.
Decrease his milk, his lactose
Yeah,
intake.
absolutely.
No,
There's a lot of, if she doesn't want to do the polyethylene glycol, there's a lot, that's just really, to move everything through. There's a lot of dietary changes. You guys are given some great options. Cut back on the milk, increase The apple juice is great at moving things through. We do want to make sure that we're encouraging her to use one that doesn't have a lot of sugar. Increase the fiber. Yes, all of those are great options if she does not want to do the medication. All right, now we're going to get into some of the things that can go wrong, some of our specific disorders that you guys need to be familiar with. The first one we're talking about is called Hirschsprung's disease. You may also see this in the literature referred to as aganglionic megacolon. They're the same disease, but what happens here is the ganglion cells that are present in the rectum that help move that stool through are absent. Okay, so we think about the process of peristalsis. We've got those little finger-like apparatuses in those ganglion cells that help really pull that stool through. So it's not that the body is not capable of making stool. It gets all the way through the intestines, gets down to that rectum, and there's nothing to help push it through. Okay. So this is a mechanical obstruction because we are not ready. We don't have the capabilities of moving that through. Okay. So let's talk about some of the side effects. In the newborn, typically, if it is, if the issue with the ganglion cells goes up high enough in that rectum, this is something that we're going to identify early on in the newborn period, because we know within that first 24 to 48 hours, we need that baby to pass that meconium. Okay. So if that child does not pass that meconium by that 48-hour mark, we start to get concerned and we have to go through our diagnostic process. Okay. So one of the things that we can do is that barium enema, we watch that child ingest that contrast. We follow it on radiology to see where it goes. And then what we would see with Hirschsprung's is it's going to make its way all the way through the intestines. It's going to get down to that rectum and it's not going to go anywhere. If we have a meconium ileus to start, that's also something that we're going to see. So we're going to look for that before we do that, that bilious, the barium enema. Okay, looking for that ileus to start. Typically that ileus is going to be right there at the rectum. It's going to, the meconium is going to work its way all the way through. May also see some feeding intolerance. The child feels full, so he has no desire to eat. That bilious vomiting is always going to be a huge red flag that something is wrong. All right. Bilious vomiting in almost every situation indicates that there's some type of obstruction. Where that obstruction is can be very dependent on what's going on. But bilious emesis means that the food has gotten through the stomach, has passed through that pyloric sphincter, has made contact with the duodenum, and then there's a problem. Okay, because it's mixed with that bile, that's what gives it that bilious or that green appearance. If we have milk that is just white, or formula that's just white when that baby is throwing it up, we still have a problem, but the problem is in our stomach or higher. Okay. So, big difference. If we have bilious vomiting, it means that that food has made it through the stomach and by the duodenum is been able to mix with that bilious food. Never, ever, ever normal. Always something that we have to look at. The abdominal distension comes from that ileus, from that obstruction. Okay. If we had a baby that was able to pass enough stool that we didn't really clue in that something was going on, then we may not detect this until infancy. And we're going to start to see that FTT is that failure to thrive that we've talked about. Okay. Constipation, abdominal distension related to that blockage. This child is going to have some ganglion cells in his rectum, but not enough to really move everything through effectively. That's why he gets that constipation. Okay. May also see that diarrhea and vomiting. That can be from him feeling too full, not being able to process all the food that he's ingesting. There's no room for it to go because of that ileus. Okay. The ominous sign or the big, severe critical sign in infancy is that explosive diarrhea. That can indicate that we have enterocolitis. That infection is related to that stool just sitting, causing that obstruction. Okay. If we don't have a major issue, if we're just missing some ganglion cells, we may not diagnose it until later in childhood. If you think about the process of development, our rectum starts very small, so we just need some ganglion cells initially. Through infancy, that expands a little bit, and we may still be able to process our own stool at that point. By the time we're older, let's say 4 or 5, that rectum has expanded. Now we need more ganglion cells to move that stool all the way through. So if it wasn't a major issue, we may not recognize it until childhood, when that child has grown a little bit more and needs more ganglion cells to move his stool past his rectum. Okay, so what we would see in these children, ribbon-like stools, because it's able to pass a little bit, but not super effectively. It's foul smelling because the body holds on to it longer, right? The stool sits there, bacteria has the opportunity to breed in there a little bit more, increases the smell there. Okay, abdominal distension. We may also see some visible peristalsis, where we see the body trying to move the stool through in the abdomen. And because they're not able to get the nutrients that they need from the stool as it's being formed, we may also see them appear malnourished. That can also be secondary to feeling full all the time and not really wanting to eat. Okay, regardless of when we notice, hopefully, it's a congenital disease. It's not something that just one day happens. It's really a matter of when it presents a problem for that child, to give some red flags to either the parents or the pediatrician that we've got a problem here. Okay, so most cases we're going to identify in the newborn period because they did not pass that meconium. Mild cases may make it through infancy, and super mild cases may make it into childhood. Everyone understand why we may not get it until childhood, may not diagnose it until childhood? Yes. Okay. Regardless of what type, if we suspect that we have Hirschsprung's, there is a very specific thing that we're going to do. We talked about that barium enema. Once we see that is where our problem is, we're going to do something called a rectal biopsy. And unfortunately, I've seen this procedure done many times in the NICU. But what happens is that, the apparatus looks like a little gun. The biopsy tool on the end is covered in lubricant. We slide that into the baby's rectum. We squeeze the trigger. It basically gives us a hole punch out of that rectal tissue. That's our biopsy. Send that off for testing. Absence of ganglion cells is going to be confirmatory for our diagnosis of Hirschsprung's. The only thing that's going to help this child is surgical correction. Okay. The extensity of that surgical correction is based on how high up the lack of ganglion cells go. So if it's not until the very tip of that rectum, we may be able to just cinch down that tissue and not have a major problem. Okay. If we have a complete absence of ganglion tissue in our rectum, now we're going to have to remove all of that tissue and pull down our intestines. So we may lose a little intestines depending on how big our problem is. Okay, so we have to remove that aganglion cell. We're going to do that pull through maneuver where we pull down enough tissue to create a rectum where we're able to start that peristalsis that's necessary to move that stool through. How would you know post-op? How would you know that the surgery was effective? The way that you would know your surgery is effective after this procedure is just the return of normal stools. Okay, being able to see that is going to give you the big clue that there is enough peristalsis happening in the rectum now that we've returned or we've established a normal bowel movement pattern. Okay, other thing that you're going to be looking for here, obviously post-op, is signs of infection. You can see listed there may require daily rectal dilatation. This just means that we go in and either digitally with our finger, or if we have some tool, we just open up that tissue, that area just a little bit to make evacuation of stool a little bit easier. Okay. All right. So some nursing considerations here. The only correction is surgical. So we do want to prepare the parents that in anticipatory guidance, the child is going to need that surgery. We monitor for abdominal distension. We watch those vital signs. If we had a major repair, if we had to go high up into the intestinal tissue to find enough tissue that had the capabilities of providing peristalsis, that child may end up temporarily with an ostomy. The other potential for an ostomy is if we diagnose this early in newborn period, we may opt to allow that child to grow a little bit before doing the surgery so that he's more prepared, which means that he still needs a way to evacuate his stool. So he may temporarily have an ostomy. Okay. The ostomy in either condition is going to be temporary if we're able to complete the surgical repair. Okay. So if we send the child home with an ostomy, we want to make sure that the parents or caregivers are prepared to change that bag, to know what to look for, what a healthy stoma looks like, and all of that information. All right. The next condition we're going to talk about is gastroesophageal reflux. So it's not called GERD until there's actual tissue damage. So it's just reflux up until that point. Very, very common in our first couple of months, especially if that child was born premature, because they just didn't have an opportunity to be born with a mature GI system. Okay, so something we deal with a lot in the NICU, and can also happen to a term newborn as well. Okay, what's happening here, or what we see in this child, is that they tend to vomit before. Can be during the meal, can be shortly after. Their body just needs a little bit more time to process that food. Okay, so this is not going to be bilious vomiting. It's non-bilious because it doesn't make it past the stomach. Okay, for most children, this is something that peaks at 4 months. If we're not dealing with prematurity, peaks at 4 months and resolves itself by the age of 12 months, typically much sooner than that. Okay. All right, so what are we going to see in these children? The vomiting is a big red flag. It's important that we educate our parents the difference between spit up and vomiting. Spit up happens typically with a wet burp. We're burping the child and just a little bit of that milk or that formula comes up. Nothing to be concerned of. We all have those burps that are not just burps, that a little bit of our food comes up. That's all that's happening with spit up. Very different than vomiting. So we want to make sure that we're explaining that difference to our parent. First time parents, may not really understand until they're seeing those differences. Spit up is something that happens very casually, typically after a burp, whether it's induced by the caregiver or by the child himself. Vomiting tends to be more forceful. Okay. So we see that weight loss, failure to thrive if we don't diagnose it, if we're not seeing those concerns early on. These children tend to be very irritable because they're always hungry. They're throwing up whatever they're taking in, and they never really get to that point where they feel satisfied. The other irritability point comes from how their stomach feels because they're not able to digest very effectively. Okay, can cause some respiratory problems. What's happened here, if we're seeing respiratory problems, this child has aspirated some of his vomit. Okay, so that has gone into his lungs. If we're seeing coughing, it's probably sitting right here. If we're seeing that wheezing, it's gone down. The reason that we would want to explain this to parents is because if we don't really keep an eye on that vomit aspiration could turn into pneumonia. So definitely something that we want to be familiar with. How we diagnose this, we do an upper GI series to make sure that structurally and anatomically everything looks okay. And then we do a 24-hour pH probe where we monitor the pH of the patient. The more acidic that pH is on that probe, it's going to give us that indication that we're dealing with reflux. Okay, because as we vomit, we purge our hydrochloric acid. That's going to show that we're more acidic. Okay. The treatment is based exclusively on how severe the symptoms are and how much growth is affected. If we're not seeing a major issue with the child's growth, then we're not going to, we're just kind of feed the child through it. Okay. So some small things that we can do is to give smaller feeds more often. If the mom is breastfeeding, rather than if she's, doing 20 minutes on each side, maybe we cut that down to 15 minutes on each side and see how well the baby does with that. Okay. If we've tried doing smaller feeds, more frequently, and that's not helping, the next thing we may need to do is to thicken the feed. Okay. We can thicken with baby rice cereal, specialty formulas, no adult cereals, no adult formula. All of it needs to be geared towards the baby. If shortening the feed and doing more frequent feeds is not effective. Okay. If it's something that the parents are noticing as that child gets more active, he's starting to vomit, that's the indication that it's not really, it's reflux, but not in the sense that, not your standard reflux. It's like activity induced reflux. That's one thing that I noticed with my son. When he started crawling, I saw a lot more vomit because he would finish eating and then he wanted to go play. And I'd see little, splatters of vomit just because he kind of shook up his stomach before it had a chance to digest. Okay, that's easy to remedy as well. If none of that helps, then the next thing that we do is medications. We only want to give medications if it's severe enough to either affect the baby's ability to eat, his desire to eat, or if we're seeing effects in his growth, because all medications carry some side effects. Okay. Same thing we would provide in adults is what we would give here: Prilosec, Tagamet, Pepcid, what you're seeing there, Ranitidine, Famotidine, just obviously in much smaller doses. Okay. If we're giving these medications, it's because we're seeing where it's either affecting that growth or the feeding patterns are getting disturbed. Okay. In our premature baby, this is the same course. We start with giving longer feeds. If we're doing NG feeds, or instead of the typical 30 minutes, we may give it over an hour, which gives that baby longer to digest. And smaller volumes to digest. So there's a better chance of doing that without vomiting. If we've tried that, then we go to the medications. That's not effective either. The last thing that we're going to do is a surgical treatment. Okay, it's that nisofundoplication. Typically, if we're having to go to this extreme, we're dealing with a premature baby. This is not something that usually happens with our term infants, because we can usually either through those changes in feeding or the medications are going to be enough for our term child. But the premature baby, it's related to immature structures, so that nisofundoplication may be helpful. Okay. All right. Next thing we're going to talk about is cleft lip or cleft palate. So this is something that we would be able to see on ultrasound. There's no genetic marker here, but this is something visually we can see on ultrasound if the mom is getting adequate prenatal care. It's typically a cosmetic thing if we're just dealing with that cleft lip, but if we've also got that cleft palate, or if we have a cleft palate, we have a bigger issue, because now our feeding is going to be affected. So in our pictures here, A is just a cleft lip. B is also a cleft lip, just a bit more advanced. And now on C, you're seeing cleft lip and cleft palate. And D, we've just got a massive cleft in that palate, okay? We can see this as an isolated event, or it can be associated with some of those spectrum disorders that I mentioned last week. Two very common spectrum disorders that we see are Vater, V-A-T-E-R, or Vactorel. Okay, so with Vater, we've got vertebral defects. So we may have something like spina bifida. The A is for imperforate anus, meaning that there's no opening there. T, tracheal defects. E, esophageal defects, and that R is for renal dysplasia. And then if we have Vactorel, that's going to add in some additional issues where we've got cardiac issues and limb defects as well. So anytime we're seeing this, it's always a reason to go really deep in the assessment that we're providing, okay? So it can be just a cleft lip, can be just a cleft palate, can be both of them combined, okay? The severity is going to determine how impacted feeding is going to be. We do have some specialized bottles that we can utilize. It can be really difficult if the mom wants to breastfeed. She probably would be able to get a decent latch with A, but any of the rest of these are going to be very difficult. So the cleft lip is going to affect the latch either on the breast or the bottle. The cleft palate is going to be a bigger issue with how that child is able to process, to really drink in that milk, all right? Because we can actually have full exposure of the nasal turbinates, which means that there's basically a direct pathway from the opening in the mouth into the nose, which means that this is going to be very hard for the child to swallow those feeds. So we may have to do some advanced feeding before we're able to surgically correct. All right, you can see some of our risk factors: maternal smoking, alcohol, steroids, anticonvulsants, and sometimes this is one of those things that just happens. Okay. So management is going to be a multidisciplinary approach. Pediatrics will be involved. Pediatrician will be following that baby. Plastic surgery is going to help with some of the cosmetic appearance. The rest of those are related to that child's development, okay? So ensuring from an early age that we start some speech therapy, some possible occupational therapy, all to help that child learn to swallow effectively. And knowing that if we've got, yesterday we talked about those ear infections, how frequent ear infections can cause some hearing loss. What I didn't really lean into is the way that would impact that child developmentally. If that is happening early on, he's not able to hear the sounds around him. Child doesn't imitate the sounds that he doesn't hear. Okay, so that's why we would want to make sure that speech and language are following this child as well. The treatment is going to be surgical. Okay. First, we establish a way to feed this child up until the point that we can get to surgery. If we have a cleft lip, typically we can fix that around 2 to 3 months. Cleft palate, we're going to close by 12 months. Just because the child has a cleft palate doesn't mean that he's not going to be able to eat, all right? There's different positions that we can try. If it's really advanced, he may get a G-tube for his nutrition, and then continue to work with that bottle up until that surgical career repair, and then continue to follow that child with speech and language therapy to make sure that normal patterns are being established, okay? We think about how much of our conversation happens, how much of our talking happens when our tongue hits the roof of our mouth. Even though the child is not speaking great volumes in that first year, it's important for him to really develop that pattern. So that's one of the things that speech would work with. Whichever type of repair, if we're having the cleft palate, cleft lip, or both repairs, the post-op care is going to be very similar to what we would do. We're always looking at risk of infection. We'll talk about some other things that we watch for in just a second. Okay, so big focus first is on trying to provide for that child. So I did say that there's some specialty bottles that we have. We also feed that child in a more upright position, almost a 90-degree angle, so that gravity is really doing its thing and we're not getting all that milk up in this area. Okay, breastfeeding might be possible depending on how damaged or how big that structural defect is with that cleft palate. Okay. All right, so this slide is really important. So looking at your post-op care, so always looking or always thinking about infection, but specifically for cleft lip and cleft palate, we're going to put petroleum jelly on that suture line to say that to ensure that it stays moistened, it's able to heal. For about 2 weeks, we're going to restrain that child's arms so that he's not able to pull at those suture lines. So that's a big thing that we have to do here. Children our babies are going to hate this. They don't like to be held down, but it is in their best interest. It may be possible to swaddle rather than restrain, but that really just depends on if that's enough to contain that baby. Big factor here is going to be adequate anesthesia or pain control. The better that we can control that child's pain, the less likely he is to fight those restraints, whether we're using soft arm restraints or a swaddle. Okay, start with clear liquids, progress to full feeding. We're going to discharge if the child, depending on how old he is, if he was at a point where he's taking food other than just milk, then we'll start that soft blended diet. Most of the time, this is going to be appropriate for that child anyways, because our goal is to have surgical repair done by 1 year. Okay, avoid suction, pacifier, oral thermometer, straws, hard food, all things that could affect those suture lines in this area. Okay, the biggest reason that we want to have this surgery completed by 12 months is thinking about the development of that child. The earlier we can establish normal structure in here, the more likely we are to continue to hit those milestones as far as language. Okay, anybody have any questions of things that we've covered up to this point? Not yet? Okay. All right, the next thing that we're going to talk about is esophageal atresia and tracheoesophageal fistula. So when we talked about those spectrum disorders, that Vater and that Bacterial, these often occur with both of them. Okay, there are 5 different types of EA and TEF, and just like that cleft lip and cleft palate, these are things that can occur singularly or can occur together. Okay, so you can see our normal anatomy here. Everything is separated. The esophagus leads into the stomach just like it's supposed to. The trachea is not at all attached. What we're seeing here in the second picture is this is type C. This is the most common. So we've got an atresia in our esophagus. We call this a blind pouch. You can see it's not connected to the stomach. However, our stomach is connected to our trachea. Okay, so we need to recognize this as a congenital anomaly. It's structure. It's something that the child is going to be born with. This is something that we need to recognize as soon as possible after delivery. Again, it's something we can see on ultrasound. So it's something that we could be aware of. If not, we need to recognize the signs very early. Even though we have this blind pouch, I mean, if we were to feed this kid with this blind pouch, all that's going to happen is he's going to vomit it up. That's not the big concern. The big concern is over here where our stomach is connected to our trachea. Even if we're not feeding our child, there is mucus that happens, okay? And if that mucus gets into the lungs or we feed that child and he vomits and aspirates it, now we've got a big problem that's going to massively affect our respiratory status, all right? So this is something that we need to recognize very early on. So you can see 50% of cases have that bacterial association. If we don't diagnose it early, that's what makes it a clinical emergency, because we can have all of those aspiration effects, okay? All right, so how are we going to diagnose it? The most common way of diagnosing this is if we don't see it on ultrasound, is when we are sectioning that child after he's born. Typically, we do the bulb section on a normal kid that doesn't have a lot of mucus. There's no big issue. These children, you can see our 3 C's down here: coughing, choking, and cyanosis. These children, even if they're term, even if there wasn't a big, issue at delivery, these children are going to come out choking on their mucus or on that amniotic fluid. And because of that, what the nurse would do next is try to suction. All right. So we start with suctioning our mouth, and then we go into suction our nose to make sure our airways are clear. If the child continues to choke, which he would in this condition, we're going to do that deep suction. Okay, this means we're going to pass a catheter down through that nose or through that mouth and try to get everything that is sitting in that esophagus. If we didn't know by ultrasound, this is typically where we're going to notice that, because a skilled nurse, excuse me, that has pass a catheter frequently in a child is going to feel that this one is different as she's hitting or he's hitting that blind pouch. That is going to be a huge red flag to stop what you're doing and to alert the healthcare provider that we need an X-ray. Okay, that X-ray is going to reveal our blind pouch that we're unable to pass through, and may also highlight that connection of our stomach and our trachea. Right. So we can see this on X-ray. If that is the case, this child is going to be taken into the NICU. We're going to start an IV. We're going to put in some IV fluids because we're not able to feed him. And then we're going to consult with a surgeon, because we're going to have to do a surgical repair. Okay. If we got out of the delivery room and we didn't, the child's not choking on his mucus or amniotic fluid, he makes it out to the floor, feeding is going to be a nightmare for him. He is going to have all of these same things: coughing, choking, cyanosis. One, with that blind pouch, there's nowhere for that milk to go. And then that could go into the lungs, and that's what's causing that choking. Okay, cyanosis obviously is related to that lack of oxygen that's happening. All right, so either way, we're going to get that X-ray, we're going to see this, and surgical repair is what we're going to have to do for this child. Okay. As soon as we recognize that this is what's going on with this child, we need to make him NPO. All right. If we have fed him, we're going to have to do something called decompression, which is where we remove everything that has been put into him so that he doesn't have that chance to aspirate. All right. Removal of secretions from the mouth to make sure that he has the clearest airway as possible. Keep that bed elevated to help facilitate the normal drainage with gravity. If we fed this child, it may be necessary to start some broad spectrum antibiotics to prevent the potential of aspiration pneumonia. Okay, that's something that we would be able to see and follow on the X-ray. If aspiration had occurred, we'd be able to watch that pattern for pneumonia. Okay, so we're going to need to do surgery. We do an end-to-end repair, which means that we connect things where they're supposed to be. So if we're dealing with this type C, we're going to cut this part of this esophagus that's connected to the trachea here. We're going to reconnect it to this blind pouch and then suture up our trachea, and hopefully that's the end of the repair that we have to do. But because there are 5 types, the surgical repair is going to be dependent on whatever type we have. Okay. So can see it on ultrasound, but it may not be obvious until we start to see those symptoms after delivery. Okay. There's a high survivability with this situation. Okay. We diagnose it. Surgical repair happens very quickly after the child is born. Child can go on to live a normal life. If this was an isolated event, if it's connected to that Vater or Bacteril, prognosis is going to be very dependent on how big effects those pose on that child. Okay. Everybody still following me? We're still good. Y'all want to take a break and take a quick 5-minute break?
Yes.
Okay, let's come back. What time is it? Oh, Brian, did you have a question before we take a break?
Yes. So, would you say in this emergent situation, the nurse's initial action would be to make the infant NPO?
Yes.
Above all other steps, NPO first.
NPO and suction if you're seeing anything. Yes.
Okay.
Yeah. Okay, so we'll take a break. What time is it? You can see the clock. It's 8. Let's come back at 8:31 and keep going. All right, so now we are going to talk about a condition called hypertrophic pyloric stenosis. So what we're seeing here, you can see our normal anatomy in this first picture. What happens with HPS or pyloric stenosis is we see the pyloric sphincter overgrown. So we have extra muscle in that pyloric area. And what happens is the child starts to, or the baby starts to eat. So milk goes down, everything is normal up to this point. And then as he tries to process it, it hits this obstruction from that overgrowth of tissue. Okay. This is going to cause this child to throw up. We call it high volume vomit. This tends to, I mean, I've seen pyloric vomit. I've seen it cover, clear across the room because it has that high pressure from that extra tissue. So a lot of the symptoms we talk about here are very similar to what we see with that reflux. This is just at a more intense thing than that reflux. Okay. And when we look at the vomit, getting as much information from that parent is important because the timing is critical. So we've already talked about needing to explain the difference between spit up and vomit to our parent. But with pyloric stenosis, it's typically 30 to 60 minutes after the feed because the child is started to digest or is trying to digest and is unable to do so because of that overgrowth of the pyloric sphincter. All right, you can see this is bold, which means it's very important for you. Non-bilious. All right. So bilious, remember, means it makes it past that pyloric sphincter. It's able to mix with bile by the duodenum. In pyloric stenosis, we cannot do that. That does not happen because of the overgrowth of that pyloric sphincter. So it doesn't make its way through the stomach. So it's going to, whether it's breast milk or formula, it's going to have a white mucousy appearance. Okay. So the problem's not obstruction. The problem is that overgrowth in the pyloric sphincter. These children are irritable. These babies are irritable because they're always hungry. They eat, they throw up, they eat, they throw up. They never really get satisfied because they're throwing everything up. Okay, so we can see that weight loss or failure to grow, that failure to thrive. We're going to see signs of dehydration. So sunken eyeballs, that depressed fontanelle, dry mucous membranes. The other thing that we may be able to palpate is this olive-like mass, okay? That olive-like mass we're going to feel right at the base of that stomach. That is the overgrowth of that pyloric sphincter that we are feeling, okay? Because our child has so much vomiting, if we were to look at our acid-base imbalance, we would have metabolic alkalosis because the baby is vomiting up all of his acid. Okay. So we can diagnose this with ultrasound. Typically, this is not something we're going to see on the prenatal ultrasound. This is something we'll see on the baby's ultrasound. And the course of treatment is very similar to what we do with reflux. If it's manageable, if we're still seeing growth through the child or with the infant, we're going to try to feed him through it. It's going to mean that same thing where we're feeding often and small meals. I actually was born with pyloric stenosis that went undiagnosed for almost 12 months. My poor mother fed me every hour, on the hour, 24 hours a day. There was someone that was feeding me, and I still threw up all over her. Okay. She went to pediatrician after pediatrician trying to tell them something was wrong with me. And she went through 3 pediatricians before she found one that really listened to her and said, there is something wrong with this baby. So to give some background, I was 8.5 pounds when I was born. You know, last week we talked about the pattern. By 6 months, I should have been about 16, 17 pounds, right? By 1 year, I should have been about 24 pounds, right? If we're following that triple. I was born at 8.5 pounds. By 11 months, I was 7 pounds. That's how malnourished I was. All of my baby pictures are absolutely disgusting because I look like a sickly child. You can see all of my sutures in many of my early pictures. And my mom went from doctor to doctor trying to figure it out. So that 3rd doctor finally figured it out. They had everything, you know, they did all the scans, they diagnosed the pyloric stenosis, had me set up for surgery in Dallas. It was literally going to be like 1 week after my birthday. I hit that 12-month period, and I finally had grown enough that I grew out of it. All right. So that is best case scenario. Obviously, if that had been diagnosed early on, I would have probably had the surgery. But best case is to grow that child effectively enough until they're more suitable by size for surgery, or maybe they're going to grow out of it. Okay. If not, we're going to do that pylorotomy, where we'll go in through that right upper quadrant incision. We really just shave off all of that extra tissue at the pyloric sphincter. Okay. So we may see, we saw vomiting before, we may see some vomiting after as the body tries to adjust. Again, we're going to see that metabolic alkalosis with excessive vomiting. So we're watching for that. So we may have to reestablish our balance with some IV fluids. About 4 to 6 hours after surgery, we're going to start small feeds and see how that baby tolerates that. Okay. Same things we would do for any surgical procedure. We're watching for signs of infection. We monitor for pain. We want to keep that baby comfortable. The more that baby fights, the more likely he is to vomit. Okay. So we do follow the pain. So we don't just jump into surgery. We try those other things, just like we did with reflux first. The hope is that we can grow that child enough where it's not bothering them, or they're at least a better size for surgery. Okay. All right. This next condition is called intussusception. What happens here is the intestines kind of envelopes or telescopes upon itself. And the biggest factor here is going to be about circulation. Okay. This part that is being squeezed by this other part of intestines is not adequately circulate, or is not getting enough blood flow, and the potential for necrotic bowel to occur is great. Okay. So this is the most common cause of intestinal obstruction between the ages of 5 months and 3 years. It's typically, it's something that the child can be born with, but it's also something that can occur, not necessarily something that we would see immediately after birth, but something that may happen a little bit later. Okay. But also something that the child could be born with. All right. What we're going to see, remember, we're looking for our red flag symptoms. So we're going to have an obstruction right above wherever we have that intussuscepted intestine, but this current jelly stools is something that only happens with intussusception. Okay. That current jelly, we're seeing a little bit of blood, and we're seeing mucus from that inflammation in the tissue. Okay. We diagnose this with ultrasound. Other things that we're going to see: intense abdominal pain, if the child can report that, or we may just see that irritability. Okay. The abdominal swelling or distension is related to that obstruction. Current jelly stools related to that venous engorgement and that inflammation. The bilious vomiting, remember, that's a big thing. It means that problem's not in the stomach. We've made it past the stomach. Lethargy is related to poor nutrition. and may see some shallow breathing. As that distension gets bigger, it's going to put pressure on that diaphragm. Okay. All right, so we start conservative with our treatment. The first thing that we're going to try once we've diagnosed this is an air enema. Okay, so we're literally going to puff air into the intestines with the hope that pop, out comes that intestine from itself. Okay, we try that first. If that's not successful, we can try that hydrostatic enema. If that's not successful, then we go to surgery. Okay. If we've tried one of those enemas and it was effective, and then the intussusception happened again, this child is going to get surgery because it's just something that could keep happening from weakened intestinal wall. Okay. The same way we would know if our repair of Hirschsprungs was successful after surgery is the same thing that we see here. The return of a normal brown stool indicates that we have successfully corrected that either through one of those enema options or through surgical correction. Okay. All right, the next thing we have is the imperforate anus. This is the absence of an anal opening. Could be part of that bacterial syndrome we've already talked about. When we're doing that first newborn assessment, looking for this open in the recta or this open anus is one of the things that we are watching closely for. Just like there's different categories or different levels of severity, we see that here as well. Sometimes we have what's called a blind pouch, which means that if we did a cursory look at the rectum, it looks like everything is there, but then it's not really open. There's like a membrane there between the rectum and the anus where stool wouldn't really be able to pass. So the hope is that we catch it. We're able to see that when we do our first assessment on that baby, and we see it before the baby eats. If not, the next big red flag is going to be that the child doesn't have the stool, doesn't have that first meconium. The problem is if we feed the child before we notice that there's a problem, he's going to develop an ileus because there's nowhere for that stool to go. So he's going to get a lot sicker because we fed him first. Okay, so hopefully we see that before. Once we have that indication that there is no anal opening, we're going to look at a pelvic ultrasound, may also do an MRI. The abdominal the abdominal x-ray is really just going to tell us where the stool is. Okay, if we've got a potential ileus. All right, we're going to do an end-to-end repair, meaning that we just correct whatever our problem is. Okay, so if we just have that blind pouch, that membrane tissue, we may be able to just go in and open that up. If there is no anal tissue there at all, we're going to have to create one. Okay, this is another situation where we may have a temporary colostomy if we have a bigger surgery or a bigger defect that we're dealing with. That colostomy may be necessary so that there's an evacuation route while we're trying to make a normal anal exit point. Okay, again, we may have to do that anal dilatation, making sure that that tissue can open and respond to the need to evacuate stool. We follow our surgical site, look at signs of infection, and we encourage breastfeeding if that's what mom wants to do. Okay, once we have that opening, we can start to reestablish our feeding pretty quickly. Okay. All right. The next disorder we're going to talk about is celiac disease. This is very common, or very commonly called, or that gluten intolerance, right? We have a lot of people, whether from necessity or desire, they go into that gluten-free diet. But for these children, there's actually an issue. Their body really cannot process this. You can see some of our clinical manifestations. We have that steatorrhea, from that impaired fat malabsorption. That's that foul, greasy looking stool. Impaired nutrient absorption. They're really just not able to gather any of the nutrients from the food that they're eating. May see some behavioral changes. They're irritable because they're not eating well. It could affect their growth if we're not able to pick it up. Typically, when this is diagnosed, the child is in what's called a celiac crisis. So this is acute and severe episodes of watery diarrhea, could be secondary to a GI infection from that stool having an opportunity to kind of sit in the intestines for a long period. We see those prolonged fluid and electrolyte depletions, which can affect the child's temperament or behavior. And then long-term exposure to this issue can cause emotional disturbances. This isn't the easiest condition to diagnose. And it takes following the child's history, really following that weight loss, looking at the GI disturbances and getting a good account from the parents or the caregiver to really, clue in to this is what's going on here. Okay. We can do some serologic testing or some blood work here that would show that we've got some antibodies in that blood, trying to mount a response to the gluten invader. We may also note some disturbances in our vitamin levels, our nutrient levels, and may also have some anemia there as well. Okay. We're going to do a biopsy to confirm this. We'll get a little bit of tissue from our small intestine. It's going to show us that villi, which is responsible for peristalsis in our intestines, that movement through is going to be damaged from that exposure to gluten. Okay. All right. Typically, all we have to do here is change up our diet, right? We go to that gluten-free diet. What's included here? Fruits and vegetables, beans, seeds, eggs, lean, non-processed meat. Most low-fat dairy products are in here. We want to avoid high fiber foods until that inflammation has subsided, so the body's ready to take that on. The list of don'ts is a lot bigger than the list of do's, right? So no bread, cake, cookies, crackers, spaghetti, pizza, prepared soups like chicken noodle soup. That's a big no-no. Hot dogs, lunch meat, processed foods. All of that has gluten in it. So we have to get rid of all of that, right? So important that you understand what we would feed these children, what we would not feed these children. Untreated children may have lactose intolerance. That lactose intolerance comes from a decreased production of lactose during the crisis. So it's not long-term, it's going to be temporary until we move through that crisis. Okay. All of those things that we were seeing in our serology testing, anemia, those nutritional deficiencies, those are all things that we want to correct. Complications of not effectively treating or identifying that our child needs to be on a gluten-free diet, we're going to continue to see those nutritional deficiencies. It's going to impair growth, which means that it could affect our brain development, could also delay puberty, could cause some issues with bone mineral density as well. So definitely something that we want to try to identify sooner rather than later so that we can get this child on the right diet to help him. All right. Lastly, we're going to cover just kind of a few catch-alls here. So ingestion of injurious agents could be pharmaceuticals, cosmetic or personal care products. Cleaning agents tend to be a big one. So we've talked about the need to promote safety depending on how old our child is. Once that child gets mobile, the need to follow safety becomes a bigger issue. You don't just put that child down somewhere and expect him to stay. He gets a lot more active. So things like cabinet locks or making sure that anything that could hurt him is put on a high shelf that he cannot get to is something that we want to make sure that we're doing. Okay. If you look at box 32.3 on 863 in the new text, or table 32.4, page 893 in the old text, the 7th edition, you'll get some information based on the specific types of ingestion. Remember, prevention is always our focus. We want to not allow this to happen by making sure that we're creating a safe environment. But then our priorities are very similar to what we've already discussed, right? We assess our victim, we look at our ABCs following any of those high priority life-threatening needs. We look at frequent vital signs to see how well our child is doing in that moment. Terminate exposure, which means we separate that child from the poison. We empty the mouth. If it was skin exposure, we flush with warm water or normal saline. If it was bleach or something that got onto the clothes, we want to get those clothes off. Any inhaled issues or pollutants, we want to get some fresh air. Next thing becomes to identify the agent, the poison. That is when we would want to, if we think that poisoning is an issue, call poison control, whether that's at the patient's home, if that's where we first notice this, or in the ER. So if there's something specific that we need to do based on that agent, we're able to do that. Okay. Can also prevent absorption, put the child in a side lying or sitting, kneeling position, head below the chest to prevent aspiration. But separating that child and prolonging that exposure is going to be the big focus there after we cover the ABCs. All right, tying into that is heavy metal poisoning. One of the things that is followed very closely in the first couple of years is potential exposure. When my son was 9 months, we did his first lead screening, and then we'll repeat that at 18 months. Trying to identify that potential exposure early on. What we would see in children that are exposed, pain in abdomen or joints, constipation, nausea, vomiting, prolonged exposure can lead to learning disability or delayed growth. So definitely something that we want to see these early risk factors for before it becomes a problem. All right. So some of the things that they ask on that questionnaire, do you live in or visit often a house that was built before 1950, knowing that we, at that point, we didn't really know how bad lead exposure could be. Do you live in or visit often a house that was built before 1978? With recent or ongoing remodeling, or is there a sibling or playmate that your child is exposed to often that has had lead poisoning? Because it can be passed on. Okay. Treatment is going to depend on when or how high or how big that exposure is. There's something that we can do called chelation therapy, which really just binds the lead to the medication and removes it from the blood. I think that, all right, that is the end. I don't really have enough time to get into GU, but that's okay. We can jump into that first on Monday, and then I think we'll still have about an hour to review. So that'll be good. Anybody have any questions before we end today?
Are you going to be in class lecturing on Monday, or is it still going to be Zoom? Because we have our test in mental health immediately following this class at school.
I don't have a classroom that I can use on Monday, so I'll still be in Zoom. But if you guys need to be on campus, you guys can even go into those rooms that they have on the 4th floor and do Zoom together. Just tell me in the chat who's there. But I don't have a classroom that I can be in.
Okay, thank you.
Any other questions? No. All right. I will see you guys on Monday. We'll finish up the content and get into some review as much as we possibly can. If you guys have any questions that come up, just let me know. You can send them to me through email and I'm happy to help however I can. Okay. All right. You guys have a great week.